Medicare. This is Chapter 6 in your 4D book. We're on page 96. So before we get into the text material, there's a few things I'd like to cover in regards to Medicare. This is the Medicare card, what it looks like. It's red, white, and blue. And even though this one says current, that should say old. It was current at the time this poster was made. However, that is now the old card. And we used this version of the card for 40 years before they changed it just in the last year. Well, year and a half. And you can see it has the patient's name, their Medicare number, it had their gender on it, a spot for them to sign, and it talks about Part A and Part B. We'll talk about what that means in a minute. And Medicare was still using the patient's Social Security number as their contract or their policy number. Obviously, with identity theft, that is something that was a concern. And so they went through a big process to reissue cards to every person on Medicare. And they now have a randomized alphanumeric policy number that obviously is not their Social Security number. They took off the signature and they took off the gender. But the Part A and Part B is still on there. So if you ever have a patient give you a card that is clearly somebody's Social Security number, that card is not going to get you paid. We went through this transition, and we're now to the point where if we bill with that old number that was somebody's Social Security number, we will not get paid. The transition is now complete. It took a while. They had to mail a new card to every Medicare person in the entire country, so it was a very big process. So what I usually do with my students is tell them to get a blank piece of paper to take notes on and to draw a big plus sign so that it separates your paper into 4 quadrants or 4 squares. I would recommend that you do this, but or you could just sit back and listen, but I think it's a good idea to have you actually write it. Medicare has 4 parts. And so what I want you to do is to label it A, B, C, and D. Because Medicare actually calls them Part A, B, C, and D. And then we're going to talk about the features of each of those parts. Okay? So that you can take notes on what you need to know on how Medicare operates. So, Medicare Part A. It is administered by CMS, Centers for Medicare and Medicaid Services. This is the federal agency that runs Medicare and Medicaid. This is an agency located in Washington, D.C. Medicare Part A is automatic when you turn 65. You get it automatically. You don't pay anything to get it. They just give it to you as a 65th birthday present, as long as you have paid taxes for 10 years of your working life. Those 10 years do not have to be in a row, and they do not have to be the most recent 10 years, any 10 years. You can start working at 18, work for 5 years, stop and have family, be a stay-at-home mom for 30 years, and then go back and work 5 more years. You worked your 10 years. It does not matter when those 10 years happened. As long as you did it, you'll get this. What Part A covers is hospital, hospice, nursing homes, psychiatric hospitals, and home health services. So think of all your facilities where the patient checks in and sleeps there, lives there, whether it's short-term, long-term, and then your home health. They also pay something called respite care. For right now, just write that down in your notes. When we get into the chapter, I'll explain what respite care is. Medicare Part B. also is administered by CMS. This pays for your doctor's office and your outpatient care. So this is all of the not in the hospital or not in a facility services. They also cover DME, durable medical equipment. So if you need crutches and wheelchairs and things like that, that's your DME. You do pay a monthly premium to have this insurance. So this is not that free gift when you turn 65. This is offered to you also when you are turning 65. But you have the opportunity to say no. When we get into the chapter, we'll talk about why somebody might want to say no. There is a deductible. You can see that I have on the screen what it is in 2018, 2019, 2020. You can see it's going up little increments at a time. The deductible for Medicare sat at $100 for a long time. And then they finally decided they were going to start upping it, and it went to $110, and it went to like $116, and it's incremental to the point where we are now. I don't know where they are expecting to have this end. I always thought they were going to be going to 200, but maybe they're on their way to 250, 300. I don't know where they plan to stop, and maybe they don't plan to stop. But they're doing it in increments at a time. There is also a coinsurance. Once the patient has met that deductible, the patient would then pay 20% coinsurance on all their services. However, there are some services that are covered at 100%. We'll talk about that when we get into the chapter. Then we have Medicare Part C. A and B is what's called traditional Medicare. Okay? That's Medicare as it was designed in the 1960s. As healthcare costs escalated and managed care became very popular in the private sector, Medicare looked at themselves and said, why can't we have HMOs too and save money? Medicare Part C was created out of that. Medicare Part C is optional. Nobody is forced into this. It is not administered by CMS. It is administered by other insurance companies that are licensed to do this. So Blue Cross manages it in some states. Humana. What are some of the other big ones that I see? I have a bunch that are local to Michigan, like Priority Health, and HAP runs one, but those if you're not in Michigan, you probably haven't heard of those, but you probably have ones I've never heard of. What happens with this Medicare Part C is that the patient gives up their traditional AB and has C instead. They would also give up Part D, which we haven't gotten to yet. When they get a Part C, you get what you bought. It could be a HMO, it could be a PPO, it could be a POS. It just depends on what you bought. We call this kind of Medicare Advantage. Originally, it was called Medicare Plus Choice because they really wanted to mark it on that C to give it some kind of a name that tied into Part C. But that name really fell out of fashion, and Medicare Advantage is what we now call it today. Why would somebody want to give up their traditional AB and go to this? What are some of the reasons somebody would do that? Well, they have increased options. Sometimes they cover things Medicare doesn't. Medicare doesn't cover prescription drugs or glasses or hearing aids. Some of these Advantage plans do. They also allow the patient to use a medical savings account, which has a lot of tax advantages. So those are some of the main reasons somebody would do this. Medicare Part D, D means drugs. Up until the 90s, nobody on Medicare had pharmacy coverage. And of course, your people who are in their later years of life take a lot of medications. They have high blood pressure, they have diabetes, they get congestive heart failure, they have all these long-term chronic problems, and they take a lot of meds. Well, there was no pharmacy coverage. Well, finally, Congress in Washington, D.C. got together and addressed this problem, and Medicare Part D was actually signed into law by President Bill Clinton. So So you can see how recent that was. I know 20 years ago it doesn't seem so recent, but it is. This is also processed through a third-party payer. This is the pharmacy coverage is based on what's called a formulary, which is like a list of what's covered and how they cover generic drugs versus your brand name drugs. Part D is also optional. If you choose to have it, you will have to pay some additional premium to have it. So I always like to start teaching Medicare using that information before we jump into the chapter. So now let's move to our textbook and go through it. So I had mentioned CMS. Medicare is administered by the Centers for Medicare and Medicaid Services, CMS, which is a federal agency that is a subset of the Department of Health and Human Services, DHHS, also in Washington, D.C. They set the policies. What's covered, what's not covered. Certain things do take an act of Congress to change, and other things DHHS can do on their own. There are the 4 parts, A, B, C, D, we already talked about. Okay, so I don't need to cover it again. So how do you get Medicare? I had mentioned in the slide for Part A that you just have to turn 65 and pay taxes for 10 years. And that is one requirement for getting Medicare. But there's more. You also can have Medicare younger than 65 if you are disabled. You can be a disabled worker of any age and have Medicare if you become disabled. We also have disabled workers who qualify for SSI, Supplemental Security Income, disability income. That's another qualifier for going on Medicare at a younger age. You could also have adults who were disabled before the age of 18, and they can actually draw Medicare based on their parents' eligibility. I have a young man in my office that we started treating when he was under 18, and he actually went on Medicare on his 18th birthday. Okay, he went straight from Medicaid prior to his birthday and Medicare after. He is severely autistic, and so he has been qualified as permanently long-term disabled due to the autism. He is very low functioning autism, and he's been on Medicare since his 18th birthday. So that can happen. There is one disease specifically named by Medicare as a qualifying disease, and that would be end-stage renal disease or kidney failure. Once a patient is diagnosed as end-stage, which is the worst kidney failure, you automatically go on Medicare. So this is not the person who's in the earlier stages and they're just getting dialysis once a week and they're still functioning. End stage is actually considered stage 6 of kidney failure. So you can have people at stage 1 through 5 who are not on Medicare. But once they reach that worst stage, end stage, stage 6, they'll go on Medicare. Medicare will also cover for the kidney donor who is donating the kidney to somebody who's on end stage. Now, that kidney donor isn't on Medicare for everything, just the kidney donation expenses. So what they're doing is paying for this person to get healthy. So those are our qualifiers to be on Medicare. So how do you get on Medicare? We talked about qualifications. You will actually get a packet in the mail about 3 months before your 65th birthday. And you'll get this whole Welcome to Medicare booklet, and you'll get your card in the mail and all of that kind of things. Okay. Now, when you're younger than 65, obviously they aren't going to send you that until you're qualifying for Medicare. So for somebody who's disabled, this is how it's going to work. You're going to file for disability with your own state. Your state will determine your eligibility for that disability request. Once you are deemed disabled, you will actually go on Medicaid for for 24 months, 2 years. Now, some people, it's a temporary disability, and they'll lose their disability qualification. Maybe they were in a car accident, and they had a lot of problems, but give them 12 months of rehab, and they're good again. They're functioning again, and now they lose their disability rating. So people, when they're first disabled, doesn't mean they're always going to go on Medicare 24 months later, because they may not still be disabled. But assuming they are, once they hit that 24-month mark, then it will convert to Medicare. All right. It is possible for illegal immigrants to be covered on Medicare Part A and B. In order to qualify, they have to be a permanent resident for 5 consecutive years in order to meet the qualifications. So somebody who is on Medicare, we call that person the beneficiary. Remember, they're receiving the benefit of this program. Okay. And then they'll get that card. Now the chapter is going to run through the benefits for Part A, Part B, Part C, Part D, but we already did that. So I'm going to kind of scroll past these without talking about it. I did want to mention, I did tell you that Part B has a premium, that you have to pay to have that. That premium is automatically going to be taken out of your Social Security check. So they're not going to send my mother a bill every month that she has to pay, because we all know when people have to pay a bill, sometimes people pay it late, sometimes people stop paying altogether. Medicare is not going to take that position of you're going to send in money. They're going to take it straight out of your Social Security check, so they are guaranteed to get their premium payment. So your Medicare cards say your effective date, and these dates aren't always the same, because when I'm turning 65, maybe I'm going to decline Part B. Maybe I don't want to pay that premium out of my Social Security check. The main reason that somebody would say no to that is because they're still working and they might have insurance through their employer. So let's say I'm a teacher, I'm a lawyer, I'm a doctor, and I've got good health insurance and I'm still working. Just because I turned 65 doesn't mean I'm ready to retire. So I want to work for 5 more years. So I cannot decline Part A. Remember, that's automatic and I don't pay for it. So since it doesn't cost me money, they don't let me refuse it. But Part B, because it costs me money, I'm allowed to refuse it. So I can do that. And so that's why somebody might make that decision. Okay. This chart talks about your Medicare Part A benefits. And they don't pay everything. They pay, if you're hospitalized, the patient's going to owe $1,340. Now, this is the 2018 numbers. So if I get hospitalized, I'm going to get a bill for $1,340 for my hospitalization. Whether I stay there 1 day or 10 days, my amount doesn't change. Medicare will pay the rest. Now, if I stay long time, then I'm going to get a bigger bill. Okay? And they will not pay beyond 150 days. So if I'm in a hospital, an actual hospital, for 150 days, that's a really long time. Most people are either sent home or sent to a nursing home at that point. But let's say I'm still there. Medicare stops paying completely, meaning the patient's going to get the bill for all of it. Every day, every penny. So you might look at that and go, wow, that's a lot of money. That's a lot of cost that this patient's going to owe. We can add to the fact that nursing homes, they only pay for, they pay for 100 days of a nursing home. Now, when you think of the elderly population, A lot of them go into a nursing home and stay there until they die. Medicare only pays 100 days. That's it. Then the patient has to pay the rest. Okay. So I'm going to scroll back to the Medicare Part A, and we're going to talk about a benefit period. Right here. A benefit period starts when a patient checks into the hospital. And it ends when I go home from the hospital. But it doesn't stop there. It doesn't end until I have been home for 60 consecutive days. So if we send a patient home and they come back to the hospital during those 60 days, we're in the same benefit period. And then we discharge them again. And they make it 40 days and then they're back. We discharge them again. They make it 20 days and they're back. This was exactly how the last year of my father's life went. He was constantly back into the emergency room, and they usually admitted him. And for actually 11 and a half months, he was in the same benefit period the entire time because he never hit 60 days at home. So, the good thing about that is that this $1,340 is per benefit period. So he only got one bill like that for the whole time. But the bad part about that benefit period is that you can easily hit that 60-day mark. Now, they don't count the days you're at home. So they count the day you're admitted, however many days you're there, and then they stop counting. And then they continue counting when you come back. And then they stop counting. Keep counting. Keep counting. So for that final year of life, my dad easily hit that 60-day mark. And it put him into the next category of where he was getting a bill for $335 a day. Later on, we're going to talk about patients having insurance in addition to Medicare. I just want you to understand why it's important, because this is a really expensive cost. Okay? It adds up really quick. Okay. Part B. Oh, nope, there was one more thing with Part A I wanted to talk about. Respite care, right here. Respite care is a term used when you have somebody who needs round-the-clock care, but they're at home. So their wife might be taking care of them, their husband's taking care of them, maybe their adult children are helping, maybe we have some nursing assistants come in. And what respite care is it allows a temporary admission to a hospital or nursing home to give relief to the caregiver. We're giving the caregiver a break. Now, sometimes that respite care might be in their home, where they will pay for a nurse to come in for 5 hours a day to give the caregiver a break. I went through this with my father. My mother was run ragged in that final year, and she couldn't get to the grocery store. She couldn't go to church on Sunday. She couldn't get a haircut. She couldn't even go to renew a driver's license or go to her own doctor's appointments because she couldn't leave my father. So I'm one of 6 children. We pitched in. We gave her that assistance. She got nursing assistance towards the end. All of those kinds of things. Well, what if you have that caregiver who has a child who's getting married out of state? So we're just going to tell that person they can't go to their child's wedding because they're taking care of their spouse? That's not a very fair thing to say to that person. Now you might think, okay, but why is that Medicare's problem to pay for a hospital stay? Let's be real. It is cheaper to have the spouse care for that person at home than it is to put them into a nursing home. and we have to pay for 24/7 care, which could happen. You run that caregiver into the ground, they're exhausted and they're stressed, they're just going to say, fine, it's time for a nursing home. And so we don't want that either, because it's cheaper just to pay for the short stay and have them stay at home. So this is a great way to bridge that difference between home care and full-time assisted care, and keep that caregiver going in their energy and devotion to their spouse, because it's an exhausting way to live. Many of you may have experience with that as well. Okay, Part B, we had talked about how there was a deductible and that most services were paid with a 20% coinsurance. I just want to show you the chart of kind of the coinsurances. So you can see there's 20% on these things. But then all the ones I didn't mark are 100%. If you look at the ones that are 100%, a lot of them are screenings. So like your preventive type things. The ones of when you are ill, like your ambulance ride and blood work and other therapies, that's where you typically will have that 20% coinsurance. Now there is a one that says 50%. I think it's your mental health. Yep. And that's true for most private insurances as well, as a 50%. I think that's the only one that's not an 80 or a 20. I'm sorry, an 80 or 100. That's the only one that's some other number. Okay. There are some screenings on some of these as far as frequency. Colonoscopies, once every 120 months. It's like 10 years. Now, if you're high risk, they'll pay one every 2 years. An electrocardiogram, an EKG screening, which means no symptoms, they'll only pay it one time ever in your lifetime. Now, if you have symptoms, that's not a screening, and they'll pay it as many times as you need if you have symptoms. A glaucoma screening, again, once every year, because that's a common disease with elderly. Pap smears, once every 2 years if you're low risk, and once a year if you're high risk. And this is the one that usually blows everybody's mind. A physical exam, like a wellness physical, one time, the first 12 months, and that's it. They do not pay for physicals for senior citizens. Now that blows a lot of people's minds that they don't. But let's be real. Remember, wellness and physicals are when you have no problems. Most of your senior citizens have problems. And so normally they're not going to be wellness exams. They're going to be sick exams because we're evaluating their diabetes or their blood pressure or their cholesterol or whatever it is. So it's not that crazy, but at first glance it seems a little surprising that that's how Medicare covers it. I want you to know the ones I just talked about. Colonoscopy screening, EKG screening, glaucoma, pap smear, and physicals. Remember, those are all wellness. Okay? There are screenings on them because you are not ill. There are no limits on the things that you are ill. They will pay for an ambulance ride as many times as you need it. They will pay for your blood work as many times as you need it. Therapies, other things like that. Okay? All right. All the other A, B, C, D stuff we already talked about. So I'm going to skip it here because I covered that before we got into the textbook. Okay. I want to talk about railroad. Railroad Medicare is something completely, whoops, that's not what I wanted. Hold on. Railroad Medicare is an animal of its own. Going back to like the 20s and 30s, railroads ran this country. It's how we shipped all goods. We weren't really a trucking industry yet. Planes, of course, were just being born, all those kinds of things. So railroads ran our country. And it was just not acceptable for the railroad industry to strike. Well, they did go on strike. So the federal government got involved in the strike negotiations, and there were a lot of concessions made for the railroad workers. And you can imagine if the government is a third person, you've got the union, you've got the employer, and now you've got the government sitting at this table. And the union wanted certain things, and the employer could give certain things, and guess what? The government said, we'll give you things too to stop striking. There was a lot of things given at that table. If you've ever been involved in doing taxes, if you're retired from railroad, doing your taxes every year with the IRS is different than everybody else. But so is your Medicare. That's something that also got tied in. Now, I know Medicare didn't exist in the 20s and 30s, but it got tied into this through the years. So what I'm telling you is that when a patient has Medicare through the railroad, their card actually says railroad, and they are a world of its own. You bill it to a special place. It's paid through a special company, but it's still got that Part A and Part B. The patient's copays are still the same. It's just processed differently. It comes out of a different budget at the federal agency. Okay. Sometimes patients have Medicare and they're still working. I mentioned earlier about the person who wasn't ready to retire at 65, so they keep working. But you also have the person who does retire at 65 and then gets bored. And so at the age of 80, they decide to go be a greeter at Walmart just to get them out of the house and talk to people. And they enjoy it. I know that my local store has somebody that's this really friendly old man. I love seeing him at the front door. Like, he's super sweet. So you could have people who are working at 65, not ready to retire, or they went back to work or whatever. And Medicare has different policies for your employed elderly people. It is possible for Medicare to be the secondary insurance, meaning that some other insurance pays first and Medicare pays second, which of course changes how we have to bill, because we have to bill it in the right order. So as a biller and an office, we have to be able to keep track of when Medicare is first and when Medicare is second. Fortunately, we don't have to make that decision completely ourselves, because Medicare is going to make that decision, and I just have to look it up and know that I'm doing it right. The third reason that Medicare can be secondary, and this happens a lot, is if you have somebody, let's say you have a man, I'll give a sexist example because we'll make the man older than the woman. The man's turning 65 and ready to retire, but he has a younger wife. And the wife still works and has insurance, and the husband is on the wife's insurance. This happened with my aunt. She married a man 15 years older. And so he was retired and on Medicare, but still on his wife's insurance. You could have a woman with a younger husband that works too. Same example. I scrolled just a little bit and then I'll go back and catch the part that I skipped, because here's where they talk about that Medicare secondary payer. So I just want to stay on topic. So when would Medicare be secondary? Is if you are still working or your spouse is still working and has health insurance and there's more than 20 employees who work there. You could also be disabled and be on your spouse's insurance, or even perhaps your parents' insurance, because remember, you can stay on your parents' insurance till 26. So if you're 22 and disabled, you might still be on mom and dad's insurance. Maybe your injuries are work comp. Work comp needs to be paying this bill. Could also be a car accident. I lump those two together. There's a disease called black lung. It is actually a coal mining disease. So it would be a disease contracted by people who work in the coal mining industry. And if you have black lung disease, then the federal government has a black lung program that should be paying your medical bills, and they'll pay before Medicare as well. You could also be VA and have Medicare, so the Veterans Administration is paying your bills. Okay. So those are some of the main reasons that a patient would have Medicare be the second insurance when we're billing. So I had mentioned earlier about how there is still a significant amount of cost to the Medicare patient and that they should not only have Medicare. Now you can, absolutely, and you'll get all those bills in the mail as you seek medical services. However, you're in a much better financial position if you have a secondary insurance. So the first secondary insurance we're going to talk about is Medicaid. There was a time when a person could not have Medicare and Medicaid. You had one or the other, never allowed to have both. Well, then somebody decided intelligently that you can be over 65 and still be low income. Absolutely, that's possible. And so they changed the law that you can have Medicare and Medicaid. So if a patient has Medicare and they qualify for Medicaid, they'll have both. When we bill Medicare and they process our claim, they will directly cross over, meaning they'll send the claim to Medicaid for us. So in the doctor's office, we don't have to do the paperwork and send the claim. They do it for us. So Medicare will pay us, and then Medicaid will automatically process it as the second insurance. The next type would be somebody who doesn't qualify for Medicaid. They might have to go buy a second insurance themselves, and we call that a Medigap plan. So if Medicare pays this, but it doesn't pay this, we call that the gap. That's the part the patient would have to pay. And so if I buy a Medigap plan, I'm saying, okay, second insurance, you pay this part Medicare doesn't cover. And that's what they do. And they pay it based on what I purchased. There are a number of Medigap plans that can be sold. These are federally regulated, meaning the federal government designed these. You can see some letters got skipped. Those are ones that are retired. So there used to be a J. There used to be an E. They've been retired, so they're not for sale anymore. I can buy Medigap from a dozen different places, or 36 different places, but these are the only plans that they can sell. So really, I can compare apples to apples. If I want to buy Plan G, then I can price shop. Okay. So what is the difference between these? Not a lot. This one. Oh, take it back. We're going to do it this way. Very little is different between many of these. Well, I guess so. You can see a lot of things are the same between shopping for plans. So, is Medicare Part A, what do they do with it? Medicare Part B, what do they do with it? Do they pick up the deductibles? Do they pick up the copays? And you get what you purchased. Okay? A lot of times your insurance card will say right on it, Medicare Supplemental Plan N. This one here is being phased out, the one that covers the Part B deductible. They're actually not selling this one anymore. They replaced it with this N that does not cover the deductible. They really want the Medicare patient to pay that first $200 in bills. They feel that that makes them invested in their health care if they're going to get a bill for it. Medigap plans are also going to be a crossover to where Medicare is going to pay the bill, and as long as they know about the other insurance, they're going to send that claim to the other insurance for me. So that's great. Managed care did get their hands into Medicare as far as with the Part C. We talked about that already. We talked about car insurance and how you're going to bill a patient's car insurance and then bill Medicare as secondary. Okay, so Medicare has a number of programs. Now we're going to get into the how do they pay it, and every now and then, at least several times a year, you'll hear some article or some news report about some doctor being busted for Medicare fraud. So now we're going to get into how do they monitor some of those things. How do they catch those kinds of things going on? Well, one of them is called the QIO, Quality Improvement Organization. This department of Medicare reviews for medical necessity. So the way the QIO works is that you bill Medicare and they pay you. They're just going to assume you're on the up and up and you have good medical records and you can prove everything you billed for. So they're just going to trust you and pay you. Then the QIO is going to come along and they are going to randomly look at medical records. This is random. So when you get a QIO records request, don't think that they think I'm doing something wrong. No, it's random. They pick a state, they might pick a specialty, and then they pick 100 doctors from that specialty. So it just means that your number got pulled. It's not a big deal, okay? It's a random audit. They request medical records for something they paid for. You send it in, and hopefully you never hear from them again. Now, if they don't like your medical records, they're not going to assume you're doing anything fraudulent from 2 or 3 records they requested. They may now ask for 10 more. Don't get worried if that happens. It could still just be a process. And then at some point, if you're doing fraud, they may come knock on your door. We're going to talk about RACs, R-A-C, and they're the ones that you do not want knocking on your door. Okay? Those ones are not random. We'll talk about that when we get to that one in the chapter. Providers. As a doctor's office, we can choose to participate or not participate with Medicare. That means we signed a contract and we agree to certain things, and Medicare is going to agree to certain things if we sign the contract. Most doctors are participating. The main reason is how many million Americans are on Medicare, and if you don't participate, those patients are likely not to come to your office. So it really hinders your patient base and can affect how much money you can make as a doctor. And so most doctors choose to participate to increase their ability to treat those patients. When we choose to become a participating doctor, we are going to agree to the fee schedule or the approved charge, meaning for every CPT code there is, Medicare tells us how much they're willing to pay for it. And guess what? We have to accept that. Most of the doctors who choose to not participate do it for that reason. They don't like the amount. Okay, that's a business decision. They're allowed to. Medicare patient pays their deductible, and then Medicare pays 80% of that approved amount. We're going to talk about these examples in video number 2. There is one math problem on your test where you're going to have to calculate a number. So we're going to go through a bunch of math examples of how they calculate payments and patient amounts, okay? So that you could be prepared for that one math question on your test. Yes, you may use a calculator on your test. No problem. No one's expecting you to do this long multiplication, okay? I will teach you how to do it in video number 2, okay? You'll be fine. Non-participating doctors have not signed that contract. Remember I said that's usually because they don't like the approved amount price. Non-participating doctors have another concept put on them called the limiting charge. Participating doctors don't have this limiting charge because they are bound by that approved amount on the contract. However, the non-participating doctor has a limiting charge which limits how much they can bill for their services. They say, okay, you don't like this approved amount fee, that's fine. We're going to let you make some more money than that number, if that's really what you want to do. But we're going to put a limit on it, because what we're not going to let you do is to charge exorbitant rates and make our elderly patients pay those numbers. So, for example, let's say I'm a participating doctor, I charge $100 for that office visit, and Medicare's approved amount is $82. So that means I have to reduce my fees to $82. Doctor down the street, who's not participating, for the same service, decides they want to charge $550, and they're going to make the Medicare patient pay that. Medicare says, no, not okay with us. You will not take advantage of our elderly population. What we will do, though, if you don't like that 82 amount, okay. We will let you make 115%. 115%. So we're going to take that $82 times 1.15. You can charge them $94.30. That's it. And the non-participating doctor says, I didn't sign a contract. You can't tell me what to do. I can charge anything I want to. And to that, the federal government says, we're the government and we can do anything we want. And you will follow this limiting charge law, because they passed it into law in Congress to be able to enforce it. So, what Medicare would then say is, you don't like that amount? Then don't take care of Medicare patients. When they call your office, send them away. That's your only recourse if you don't like that dollar amount. Don't treat the Medicare patient. There you go. End of story. Okay, so that's how the limiting charge works. I have never in my entire career worked for a non-participating doctor, so I've never had to deal with this limiting charge because I deal with the allowed amount on everything. Some services require pre-authorization. Traditional Medicare does not, but your Medicare Advantages oftentimes do. They're not going to require pre-certification for emergency surgeries. You're having a heart attack, get the services you need. Like, that's the way it works. However, anything that can be delayed, those are the things that they will ask for pre-certification. Getting your gallbladder out, getting a bunion fix, getting a hysterectomy, getting your prostate removed. Things that are scheduled out often require pre-certification. Like I said, Medicare Advantage, not typically regular Medicare or traditional Medicare. Okay. NCD and LCD, National Coverage Determination and Local Coverage Determination. These are your payment policies put out by the federal government. I'm going to do a special video on just this. I'm going to show it to you, demonstrate it. For the test, you just need to know what it is. For life, you're going to want to watch my bonus video, because for operating in the doctor's office, you've got to have a good grasp of what this is. But this is a payment policy put out by either nationally by CMS or locally by your Medicare administrative contractor, which we haven't gotten into yet, but that's who actually pays Medicare for your state. It's later in the chapter. And these are the payment policies that of when it's going to be paid, what's paid, how many will they pay, why will they pay for this service. And so there is an LCD or an NCD for allergy shots. There's one for bunion surgeries. There's one for chiropractic. There's one for physical therapy. So for the procedures you do in your office, you should be familiar with the LCDs and NCDs for what you do. So I've reviewed my LCD or my NCD, and I determine that the patient is coming in and the service they want to have is not going to be paid. So let's say we have a patient coming in and wants to have an eyebrow lift. Okay, it's a plastic surgery. Now it's payable sometimes for certain conditions. My boss, I work for father-daughter doctors. The father actually had this done. He, his eyelid was getting a little thick, a little heavy, and it was kind of not very attractive in his own opinion. The payment policy for Medicare said if his vision out of his eye was reduced by 80%, so if he had only had a 20% vision, they would pay for it. He wasn't that bad. He was just starting to have it showing. He wanted it gone before it got too bad. It was cosmetic, and he had it done. No big deal, right? So the LCD NCD says it's not payable. What you have to do as an office is have the patient sign acknowledgement that you've informed them that Medicare is not going to cover it and that you, Mr. or Miss Patient, need to pay for this out of your own pocket. If we expect Medicare to deny the payment, they have to sign this. I'm going to show you the document. We'll go through how to fill it out, which is not required for you for this test. But this is what it looks like. Okay? So we're going to put in here, this patient, wanted that B12 injection, why it's not going to be paid, and how much is it going to cost. This patient, sign this, and then we'll do the service. You need them to sign this before they had the service. Why? Because what if they don't want to pay for it? That's the whole point, is you're informing them. Okay? So this has to be signed before they incur the bill. Okay? Alrighty. This is where we are going to stop for video number 1. Video number 2 is going to continue for the rest of the chapter, as well as do some math examples for calculating copays. And then video number 3, the bonus video, is going to go through LCDs, NCDs, and more in depth on the ABN.